A hearty good morning and welcome to the Africa Harm Reduction Summit here in Joburg, Johannesburg, in South Africa. We are so fortunate and grateful for an international list of renowned speakers to join us here in Joburg. We have Dr. Derek Yach, who's calling in from the United States. He'll be very closely introduced before his remarks. And then we have Dr. Anders Milton from Sweden, who will be telling us more about the fantastic public health revolution in Sweden, where smoking prevalence is going way down to 6.6%. And we have Joseph Magero from Kenya, who will also be telling us about CASA, the Campaign for Safer Alternatives in Kenya. And on site, we have Dr. Kgosi Letlape, the president of the Africa Harm Reduction Alliance, and also former president of the World Medical Association. We have Kurt Yo, and we'll be having a panel session at the end of some remarks by each of these speakers. If I could perhaps just go through the agenda for the day so that our speakers online can see that we would start with Derek Yach, who will provide us with some insights from a global healthcare perspective and specifically in tobacco harm reduction. Then we will have Dr. Anders Milton, followed by Dr. Letlape. Then we will ask Joseph Magero from Kenya to speak, then Kurt Yo, and at the end we will have our panel session together. If I can just quickly scroll through the biographies of our speakers, just so that you have a good idea of the quality and worldwide expertise that we will have in the room. Kgosi Letlape is a South African ophthalmologist. In fact, he's the first Black ophthalmologist that qualified in this country. And when Nelson Mandela wanted to be briefed on harm reduction, he called in Kgosi. So Kgosi was a pioneer and he was a champion for advocacy of HIV/AIDS patients in South Africa, and specifically for their right to access to antiretroviral therapy. Kgosi has been a champion for the cause of patients who are battling with alcohol, with food, with tobacco, and he's been a harm reduction specialist since stepping down as a full-time ophthalmologist here in Joburg. Kgosi, welcome, and thank you very much for your presence here. Our next biography that I'd like to just highlight, if you may, is Dr. Derek Yach. Now, Derek is a son of South Africa and possibly one of the pioneers of global health advocacy, first at the Medical Research Council in Cape Town, and he was then appointed to the cabinet of the World Health Organization, where he played a pivotal role in the development of the Framework Convention on Tobacco Control. Derek has had a varied career. His cabinet position at WHO was followed up by a professorship at Yale University. He then headed global health policy at the Rockefeller Foundation, then spent several years in the private sector working for PepsiCo, where he made a tremendous impact in helping to change the product portfolios of that company and others, from snacks and soda to more healthy options for consumers. And all along the way, what Derek has done in a phenomenal way is to help lead and galvanize positive public health policy. And we are looking forward to hear his remarks on tobacco harm reduction in South Africa. Our next speaker, if I may just ask you to look at the biography of the next speaker, is Anders Milton. Anders is the quintessential health diplomat. He was the president of the Swedish Red Cross, the Swedish Medical Association, and also the chair of the World Medical Association. And this is on top of Anders being a specialist nephrologist. So as a physician and as a health diplomat, Anders has made a tremendous impact on global health policy and science. And we are so privileged to have Anders with us today to speak on the case study of Sweden, which is the country in the world which has been most successful in pushing down smoking prevalence and helping adult smokers switch to reduced risk products. And then if we can just look at the biography of Joseph Magero. We'll first start with Asanda Goyi. Asanda is the CEO of the Vapor Products Association of South Africa, and she's been instrumental in this country to help make sure that good product standards for the various devices and then access for adult smokers to vaping products in South Africa is assured. And she's been highly instrumental in engagement with the government and other stakers to make sure that as the tobacco bill in South Africa is being modified and being debated as we speak this year, that there is always a focus on the consumers. And then if we can go to Joseph. Joseph from Kenya is the president of Campaign for Safe Alternatives. And Joseph has been very active in the field of advocacy for adult smokers who want to switch to oral nicotine pouches. And he's been extremely effective as a spokesman for both consumers and other stakeholders. And eventually he deserves a lot of credit for the fact that he could help overturn the ban in Kenya on oral nicotine pouches. Any further biographies? So if we can then also just introduce Kurt Yo. Now, Kurt, you will hear from himself, is a passionate advocate for consumers. He's the co-founder of Vaping Saved My Life. And we often say that consumers are the orphans in this discussion, and Kurt has made sure that these orphans' voices are heard. So Kurt, we'll be looking forward to your remarks later today. Just moving on then to our first speaker of this morning, which is Derek Jach. You'll see on the photograph, a rather famous photograph of, on the left, Gro Harlem Brundtland, who was the Director General of the World Health Organization. Under her leadership, and really with Derek as her first lieutenant and the cabinet member who was most instrumental in the development of the Framework Convention on Tobacco Control, Derek was there, and this is a photo when the framework was eventually adopted and signed by most of the member states of WHO. So a great honor that a South African did actually do this. And I was there to see firsthand how Derek was doing shuttle diplomacy between member states to make sure that this absolutely fundamental piece of public health policy was put in place. At the time, it was the first globally legally binding treaty, which was put in place by the WHO. Just the next slide, please. Today's session is especially about Article 1D of this framework. So Article 1D of the Framework Convention on Tobacco Control refers to tobacco control as a range of supply, demand, and harm reduction strategies that aim to improve the health of the population by eliminating or reducing their consumption of tobacco. What we have found is that harm reduction strategies, these have never been elaborated by WHO or its member states, and it's largely been left for consumers and grassroots action for that to be made real in different countries. First, it was only in countries like the United Kingdom, but now there are approximately 100 million consumers worldwide who are using harm-reduced products. Yet, we still operate in a void of proper evidence-based policy in this space, and Derek will address that in his remarks. The next slide, please. This slide I would recommend you remember, because this is what Derek has shown us could happen if tobacco reduced risk products were put in place. How many tobacco-related deaths could be avoided? And he's made this estimation between 2020 and 2060, and you can see that there will be a massive public health benefit in terms of diseases controlled, and more importantly, tobacco-related deaths avoided if tobacco harm reduction policies, science, and products were allowed to be adopted in all countries. So keep this in mind as we now listen to Derek's opening remarks.
It's a fantastic pleasure to speak to all my friends and colleagues in South Africa and those who are going to South Africa for this very important meeting. I truly wish I was with you. what I hope to do in the next few minutes is really just stress how my early years in Cape Town really shaped my work and thoughts about global health in general, about the value of science, about the imperative of dialogue and engagement, especially with those you most disagree with, to make progress, and of course, to actually address the issue of smoking. Remember, this was the period of apartheid. This was a period when there were deep schisms in society. This was a time when there were a range of health issues. It was into that I actually stepped into medical school. And in 1976, led a delegation of medical students to Rembrandt Tobacco Company to try and see whether they had any argument to use to explain why we shouldn't be launching campaigns against them and to promote smoke-free campuses. Remember, by 1976, virtually no country in the world had yet put in place tobacco control programs. We were ahead of the curve. It was only in 1970 that WHO first declared the fact that smoking kills. To some extent, we succeeded. And I think from that, I certainly learned the importance of organizing. That was how it started. But I was truly inspired a few years later when Mike Muller, who most of you would never have heard of, he's currently Professor Emeritus at Wits. He'd been head of the Development Bank of South Africa and the first Director General of Water Affairs in the Mandela government. But way back in 1978, he was working for a small British charity called the War on Want and wrote a book called Smoking in the Developing World, The Coming Epidemic. That scrappy book, which I still have, provided the insight into what we needed to do if we were going to stop the epidemic being confined to developed countries and actually ensure that we didn't have the problems that happened over the next few years. I mention that because, again, it shows that high quality foresight made a difference. The problem is that even though he raised the alarm, it took many years before there was action. I also learned from our South African days the power of data and the power of getting the information into the right hands at the right place. And the most important early work that we did was to complete an entire edition of the South Africa Medical Journal devoted to World No Tobacco Day 1988, which was the first World No Tobacco Day. And even though South Africa was banned from WHO, we believed that we should lay out the argument from an epidemiological point of view, from a legislative point of view, from an economic point of view, on the value and importance of tackling tobacco as a future threat to the health of South Africans. We did that, hoping there'd be somebody in the union buildings who'd listen. And even though this was still the end of the President de Klerk era, he invited me up to his office, and I had a chance to talk about the need for him to quit as a sign that he was going to take legislative action. He eventually did, and Rena Venter, the then Minister of Health, responded with what was to become the first legislation, very modest, still pretty good, to start addressing tobacco control. I had to wait many years until the ANC was in place before we got real legislation. And for that, we had preempted the election in 1994 by inviting Nkosazana Zuma, then working with me at the MRC, to a meeting in Harare, which was probably the first and only time where you had 25 to 30 countries representing the major African countries committing to address tobacco control with a support sent out by the then President Carter, saying that this was an important issue from a public health point of view. That meeting galvanized South Africans and Africans in ways that became very important during the Framework Convention. It also was a meeting where my friend and colleague David Sweena came all the way down to make one very powerful point: taxes matter more than anything else. That message wasn't only important in resonating in Harare, but it got into the hands of Trevor Manuel, who became the first finance minister in the Mandela cabinet. And as you may know, he raised taxes above inflation for 10 years consecutively, leading to either a halting and partly a slowing of the tobacco epidemic. It was that clarity of purpose that really mattered in those days. We were focused on science. We were focused on what the epidemiology was telling us. And as the transition towards the Mandela government was happening, we were being asked as epidemiologists, how can you have the biggest impact on public health problems in South Africa? The issues on the table then were maternal and child health, stunting and undernutrition in kids, tuberculosis, and we managed to have tobacco put up there, and that's why it got the attention it needed. Well, that was a long time ago. Let's jump forward to today. If you read the South African Medical Journal edition just 2 months ago, you'll see that a group of bioethicists and clinicians from WITS wrote that the plethora of unvalidated information, known as the infodemic, is muddying the waters not only of public perception, but also of patient care. They were referring to COVID treatments and vaccines, but they could have been referring to the HIV/AIDS approach 15 years ago, or, as you will discuss, tobacco harm reduction today. You might recall how President Mbeki and his team, supported sadly by many researchers and community leaders, refused to endorse the use of antiretrovirals as the AIDS pandemic was raging, and instead suggested the use of baobab tree extract and other exotic treatments. Many in the media thought this was a joke. Many in public health laughed at this and ignored it, but it proved to be deadly. In 2008, Professor Nicola Natras, professor of economics at UCT, and Harvard researchers separately estimated that over 330,000 people died because of this policy between 2000 and 2005. With Mbeki gone, science returned. Antiretrovirals got used. The longevity decline that we'd seen during the height of the AIDS epidemic in early years actually got restored to growth of life expectancy. Science, epidemiology, and leadership from health returned, and some of the hocus pocus ideas got dismissed. People with AIDS marched in favor of decent treatment. Nothing for us without us became the mantra of their call that led to discussions of the WTO changing the patent laws, providing availability to life-saving therapies. People like Slim Abdul Karim arose to become a leader in the field and not only played a role during the AIDS pandemic, but during the latest COVID pandemic, became one of the leaders building on the excellence that had been established during the AIDS years. So what has this got to do with what you're talking about? I tried to get an update on tobacco-related deaths, but only found estimates from 2000, for which they were citing that 44,000 people die a year of tobacco-related death and disease. Very importantly, we forget that in the South African setting, tuberculosis is actually the largest single contributor to tobacco-related deaths, with lung cancer, COPD, and then cardiovascular disease being very important. If you do an estimate, you'll find that about 220,000 people die of tobacco-related diseases every 5 years. Of those, we know that among the TB patients and the COPD patients, 70% smoke. Yet I'm still unaware of a single major effort to address their smoking status. So as people are treated for TB, they will go on to die of tobacco-related deaths. Those who have their COPD managed will not have the underlying cause that's causing it, smoking, ever addressed. Given the lag between smoking and deaths, and the lag between cessational switching and life saves, we can guesstimate that these numbers will continue for decades, even if no young people start smoking today. And this is a very important point. If we're interested in adult health, and adult health matters, we really need to focus far more on the health of smokers today. They are the ones who will be dying in the next 20, 30, 40, 50 years of smoking-related deaths. Not one single child who doesn't start today will actually benefit before the next 50 years have actually arisen. So what could we do to accelerate declines beyond WHO's prescriptions of taxes, cessation, and ad bans, all of which do need to be the bedrock of any decent tobacco control program? I know that you'll hear a lot about what happened during the period of the lockdown and the prohibition, but for now, I think the main thing one needs to learn is what you all know. Let's learn from Japan, Korea, Lithuania, and Greece about how heat-not-burn products are displacing combustible cigarettes at numbers that we never achieved in public health. Let's learn from Sweden, Iceland, and Norway about the power of snus, not only displacing cigarettes, but showing that those countries, particularly Sweden, now have among the lowest cancer death rates in the world, and Sweden will very soon be declared smoke-free according to the criteria of WHO. Let's learn from New Zealand, the UK, and the US about the value of e-cigarettes, also displacing combustible cigarettes. As each category grows, we have seen profound drops in combustible use. And we know from work on biomarkers, on toxicology, on epidemiology, on clinical studies, that this will in time lead to equivalent declines in death and disease. In fact, that scientific body of evidence is what has to be put before the US FDA before they can deem something as being appropriate for the protection of public health. And let's remember that the world's leading regulatory authority, with the deepest focus on science, has already deemed that a wide range of products, from heat-not-burn to e-cigarettes, to snus, to nicotine pouches, and of course e-cigarettes, all fulfill the criteria of being appropriate for the protection of public health. Difficult to understand how other countries with less high qualified scientific regulatory authorities are able to not go along with this leadership in the way they went along with it when it came to the vaccines for COVID or the drug treatment for COVID. I think that if we are not going to take the action we need, I fear that we will have to wait and see more studies like Nicolas Natras did, showing the consequences of government policies that have banned, prohibited tobacco harm reduction on people's lives. What is the size of the prize at stake here? My estimate is that over the next period from 2030 to 2060, and remember, we've got to take the long view. These are chronic diseases. Between 2030 and 2060, on current estimates, on the current road that we're on the current status quo road we're on, we can expect between 800,000 and 1 million people to die of tobacco-related diseases in South Africa. 800,000 to 1 million dying of tobacco. But if we were to accelerate action on tobacco harm reduction, we could probably cut that by 50% over that period. That is a saving of between 400 and 500,000 lives, eclipses the deaths that were caused by the lack of antiretrovirals. If we add to harm reduction, better cessation access, which is still pitiful even in this country, and we add in better diagnostics and treatment for many of the conditions that smoking causes, we could probably bring it down further. And we need to start modeling those estimates in the way that Nicolas Natras modeled the negative impact of HIV/AIDS. Giving a sense of how many lives could be saved should act as a galvanizing force to make sure they are saved. And I hope that during your meeting, you'll focus very heavily on how can actually accelerate the progress based on the knowledge and the science that we have sitting right in front of us today. Thank you very much.
Thank you very much, Derek, for these insightful comments. And if you would allow us 2 or 3 questions, just want to make sure that we have Derek on screen.
It's Anders here. Can I ask a question?
Sure.
Anders, sure. Anders, sure. Derek, can you hear?
Yes, I can hear great.
Yes. You know, the World Health Organization today is different from it was yesterday. And the question is there any possibility, and how would we do it to influence the World Health Organization to see that harm reduction is important?
Thanks, Anders. And, you know, I wish I had the complete wisdom to give you a clear answer, but I think you partly know that it's going to be the old-fashioned way. Number one, member states need to step up their discussion and go to the World Health Assembly in May and to the COP meeting coming up at the end of the year, armed with what they believe should be their best practices. If I was sitting in Japan or in Korea or in Sweden or in the UK or in the US, I would be so proud of the achievements made with either heat-not-burn or snus or vapes and increasingly with nicotine pouches. I would want to tell the world that we have got ways of accelerating the reduction in smoking faster than the current WHO prescription. To my mind, that is the most important thing that needs to be done. Member states need to be armed with their own data. That's all they need to do, report their own data and go forward and mention it. Second, the agencies which have dug very deeply into the science, like the US FDA, need to really consider the fact that if they can declare something appropriate for the protection of public health in the US, presumably it's appropriate for the protection of public health in South Africa, as well as every other country in the world. They need to be much more strong in terms of advocacy for the power of the range of harm reduction products already authorized, and do so not waiting for COP, starting with the World Health Assembly, where there are ample opportunities to raise it. I would hope that the UK government would give greater detail to explaining the rationale for their last couple of weeks' announcements on some incredible progress in putting vaping at the center and the heart of effective ways of reducing smoking in the UK, but not just reducing it on the aggregate. They're doing what many low middle income countries need to do. They're focusing on the poorest, the most vulnerable, providing access either through cheap or reduced risk products. We're talking about harm reduction products, vapes, focusing on people in mental health institutions, pregnant women, the homeless. That story is one of real global success. And remember, it only takes one country to start the ball rolling with talking about their successes before others want to actually follow suit. That ideally should lead to the question of, well, if we're all making all this progress, why is this not reflected in the focus of the Framework Convention? And how do we activate the very definition that Dylan so well outlined that already exists? You don't have to do more than say, we have within the definition the means to actually make progress. So I think that those are from the WHO side. From the external pressure point of view, I think meetings like this really matter. Getting the message out, galvanizing non-governmental organizations around the world, engaging the physicians also matter, as always mattered at WHO. And finally, I think if we really, end up getting very concerned, think about all the new products, interventions, policies that have had to be introduced to WHO over decades. It's not an unusual thing to say, we actually made a mistake. In the light of science, in the light of new knowledge, in the light of strong evidence from countries, we agree that the time has come either for a commission or for a group of wise people to come together and say, how do we make faster progress, given that we're talking about 8 million deaths a year after all?
Derek, Jose has a question as well. And as he comes up to the podium, I just want to echo what Anders asked. And when you were part and parcel of the designing and writing team of the Framework Convention, did you ever imagine that there would be such an explosion of innovation and new intellectual property in this product space? And is that perhaps a reason why it wasn't elaborated at the beginning, harm reduction strategies?
Great question, Dylan. And I guess mea culpa to all of us involved at the time. I think if we go back to that period, remember the writing was really starting in 1998, concluded by 2003. There was a paradoxical issue going on. On the one hand, the folk writing the text into the Framework Convention never used the word intellectual property or patent once. Not once in the treaty does the word appear. Yet at exactly the same time, the HIV/AIDS epidemic was roaring. And as I mentioned in my opening address, the issue of patent access became one of the most explosive global issues among the pharmaceutical industry, the public health authorities, going all the way to WTO. And the key issue was, how do we use the new knowledge, about better drugs to lower deaths? And how do we ensure we have an equitable way of doing it? That was the central debate. So on the one hand, in WHO, you had the debate around equity, patents, and innovation as a way to actually lower death rates in the lower middle income countries. On the other, you had the folks sitting in the Framework Convention not using the term. And the reason, I think, was kind of simple. We were blinkered to a view that this was an old legacy industry. It was based on tobacco rolled up and smoked and burnt. There was no imagination to think that maybe we were on the verge of innovation that would actually separate the stuff that kills you, all the tar, all the smoke, all the combustion, from that which doesn't kill you, the nicotine, which we already knew was having a life-saving effect in terms of nicotine replacement therapy on a massive scale. That failure of imagination has carried forward all the way through to today. The tragedy, of course, is that it's meant that lives have been lost as people have not looked at the evidence. But in the meantime, what happened? We saw thousands of patents being filed by the tobacco, the vaping, and the related companies. We saw the evidence growing stronger and stronger, particularly coming from industry, showing the benefits, leading to the authorizations I mentioned earlier. So I think our lesson is, again, mea culpa. Let's accept that we didn't see the innovation that was to come. And it's innovation and the type of innovation that's actually coming to every dirty legacy sector, all the way from oil and gas to the transport sector, to the energy sector. It's not unusual. This is the era of innovation and technology giving us solutions for better health and social development. We need to grasp what's actually going on already at a very rapid rate.
Thank you, Derek. Kosi has a question, please.
Hi, Derek. I don't know whether to say good morning or good evening to you.
Very good morning. Early good morning. The moon isn't up yet even.
My question is around communication. Is it Article 5.3? The issues of not talking to the enemy. How do you make progress when you do not talk to the enemy? Should that be reviewed? I know there's issues of misinterpretation in terms of who's a state party or not, but even in terms of state parties, there are governments that are tobacco manufacturers and producers, and they've been within the house of the WHO and UN structures, and they are spoken to. But there's the issue about lack of communication. And in particular, as an advocate of public health, you see public health being holier than thou about who should be spoken to, who can't be spoken to. And you can't get the people that differ into a room so that there could be open communication and better education of the population so that the population cannot be decided for, but can make up its mind. And that leads into the issue of the current challenges that we have with COVID about disinformation. How should we treat people that hold different opinions? Should we label them? Should they be cast out? Or should we be working like with the law, where all of us sit in a room and we come out with a consensus? I mean, in the law, there are minority views, but judgments are still made. How do we get people into the room to talk? Because I think one of the key issues is to understand that even though a zebra doesn't change its stripes, you still need to engage the tobacco industry if we're going to make progress. On any other aspect, the harm producer is engaged in terms of looking for solutions to reduce or eliminate harm.
Yeah, I think you're raising some very deep and fundamental issues, Kosi, and I think, you know, knowing your background, you know that part of the answer actually is a South African answer. We think back to the 1980s when Van Zyl Slabbert met with ANC leaders in Senegal during the last few years of apartheid, when the streets of South Africa were on fire with enormous political violence. This was all done quietly. It was two allegedly enemies sitting down and trying to find common solutions. We think of Clem Sandler saying the solution is to give people a common set of metrics to understand that the future need not be what the past has been, by showing alternative futures based upon better policies. And all through that period, there was deep engagement between those who the public thought were enemies, but were slowly building forges and bonds of relationship around one thing, a common goal for the country, a safe goal for the country. That's what we should be doing. We should be digging into South Africa's rich heritage of solving the most intractable world problem that we've seen, apartheid, by doing it through deep engagement, not by continued prohibitions and bans of engagement. It's only through human-to-human contact at a very deep level over quite a period of time that people see that they may come into this with different views, but if they share the same common goal, in the case of apartheid, it was in a country that actually could flourish and grow for all people. In the case of tobacco harm reduction, it's 8 million deaths around the world. I'd hope that we'd be able to make progress. How you do it in practical terms, again, requires a greater effort, I think, to actually say that we don't demonize people who we disagree with, whatever they might be saying. We listen respectfully. We come back to them with the best science over and over and over again. We find the places where we're starting to see shining lights of opportunity, whether it's Sweden or Japan or the US, and we try and bring them together in ways that we haven't done before. I think it's a traditionally South African way of doing things, to go out into the bush, sit down around a fire and have a discussion around what do we really disagree about. We may have some disagreements, but our long-term goals for better health, better society turned out to be identical. The same should be in this field. We're just disagreeing on the technical details. And then finally, I'd say that you asked a very important question about how do you deal with people who have different views? I've followed Jay Naidu's comments about vaccines in South Africa over the last few months. And while I may disagree with him, I know that he is one of the most reputable people who was in the Mandela cabinet, who has deeply thought about these issues. And the way of actually bringing him to understand the value of vaccines isn't going to be by hammering him with critique and more data and more evidence. It's by thinking deeply about what is he really saying about our understanding and trust in science and technology, something which is also underlying the concerns about tobacco harm reduction. People don't fully understand what is behind the science that is actually allowing the FDA to say it's for the protection of public health. So in conclusion, I'd say deeper engagement, much deeper engagement is always the answer. I'm unaware of any major health, social, environmental, political issue that's been solved by continued conflict. And secondly, let's put the science of all types, of all shades out there as widely as possible. And finally, make sure that the science is relevant to the country. And I think South Africa has slipped quite a bit in terms of producing cutting-edge science in the area of tobacco control, in tobacco harm reduction, in doing the kind of modeling that I spoke about, despite the fact that it's become the world leader in doing this in terms of COVID, HIV/AIDS, with some of the best examples anywhere in terms of producing projections and modeling and surveillance that actually helps people's lives.
And then maybe before you go back to sleep, Derek.
I'm awake now. Couple of Nespressos later.
Maybe something for the future, but not too far. Before Panama, maybe we should have a webinar about COP, usefulness of COP, and transparency within COP. COP for today, not COP for yesterday. So that we should preempt the secrecy that is around COP, the lack of transparency that are around the COPs, and that as people of the world, nothing for us without us.
Again, couldn't agree more, because I think one way to do that is to maybe get the South African delegation involved in COP26 and COP27 coming up to actually explain the process that it's involved in the environmental and climate change COPs, where the full involvement of the private sector, of industry, of NGOs, of nonprofits is actually encouraged actively, and they participate in the hurly-burly of what should be a global discussion on trying to solve an intractable problem. So in one part of government, you've got folk who fully understand that. In other parts of government, and I think it's a very small part, I don't think it's the whole of the health department. I think it's a very small, internally bred group of people with a very particular view of tobacco control that has been very exclusionary, who really needs to be joined now by broader people with a wider sense of how you make progress.
Derek, you have graciously given your time at 3 a.m. your time. If I may ask one last question from the South African perspective. Just as context, the tobacco bill is being debated by Parliament over the next weeks, depending on how quickly it gets through the Health Committee. Now, in this bill, there's the danger that there's an equivalency being established between combustible tobacco on the one hand, and then non-combustible smoke-free alternatives on the other, and equivalence in taxation, labeling, plain paper packaging, and the like. If you were on the cabinet of Minister of Health, Joe Fala, how would you ensure that risk differentiation is established in the tobacco bill in South Africa to ensure that consumers understand the difference between combustibles and non-combustibles?
Well, I think like all bills, this is an opportunity for education. and to first explain what we're talking about in terms of the risk difference between these products. That I think, as everybody on this call knows, we're talking about orders of magnitude of difference between the risk in terms of death, disease, and disability of the entire category of harm reduction products, be they e-cigarettes, heat-not-burn, snus, nicotine pouches. Yes, there are differences between those categories, but they're nowhere near as important as one big difference, the difference between combustibles and non-combustibles at a very crude level. And there are obviously issues around smokers. We know when we came to lead, when we came to many other environmental factors, we wanted a future in which people would move out of the most hazardous, the most risky component of a product, be it an environmental or health product, to the healthier version. And one of the most powerful ways to do that is through risk proportionate regulation. And that includes starting with price. The price differential has to be encouraging enough to help people switch, to make the healthy choice the easy choice, as the Ottawa Charter told us all those years ago in terms of health promotion. But it's more than price. It's the messaging. You cannot have a big price differential and then say that the one is killing you as much as the other. This needs to be backed up by a marketing communication message that says, in the words of the FDA, which products are appropriate for the protection of public health and why. And stresses to everybody that we don't want kids to vape or smoke or use these products. That's absolutely fine. But don't go and let that be the sole message, because otherwise it will reach the adult smoker, which, as I said in my opening address, is really the concern for the next 20 to 30 years. If they are able to switch and encouraged to switch, that's when we will see death rates come down relatively quickly. If kids never start, that's useful, but it's not going to show up in the statistics for 50 years. And then finally, I'd say that there are other aspects of risk proportionate regulation that need to be put into effect. They include, for example, flavor and taste. We know that in any consumer good, having spent years at PepsiCo, I know that starts in the food sector. We know that consumers respond, adult consumers respond to taste and flavor and always have. It's kind of obvious that there are some flavors which will help adults switch at a higher rate. And this is backed up by an enormous amount of empirical evidence. The question of what the government would get out of it, I think can be worked out. The first thing they will get out of it is obviously a lowering of the death and disease rate over the long term or the medium term. The second is I think they'll get a spur of innovation. South Africa is losing out in the innovation battles around not just reduced risk products, but the associated areas linked to them, better lung health, addressing tuberculosis, maybe even addressing mental health in different ways, and looking at the positive aspects of nicotine long term, which may very well be kind of profound. So I think that by standing back and going along with equalization of the legislation and the regulatory approach to the harm reduction category versus the combustible will set us back and do exactly what I said I feared, that a Nicola Natras type review in a few years' time will show that we've actually foregone the opportunity to save many, many lives.
Derek, a heartfelt thanks for your early morning intervention and your wise advice to both WHO, COP10, and the South African government. We thank you very much indeed. We now move on to the case study of Sweden. Now, as Derek also mentioned in his remarks, it would be wise if WHO and its 194 member states looked at best case practice in the rest of the world. Often the end game in tobacco control is seen as where adult smoking prevalence is 5% or less. And there's a country in the world that has almost achieved that level, and that's Sweden. And just before Anders speaks, I'll just show you some contextual slides for our South African audience so that you understand what happened in Sweden, and then we'll hear it from the horse's mouth. So if we can just quickly show the slides, and then we will ask Anders to give us a first-hand explanation.
The Swedish government, as all European governments, within the European Union at least, have made smoking more difficult for the ordinary smokers. I mean, you're not allowed to smoke in restaurants. You're not allowed to smoke in outdoor restaurants. You're not to smoke basically anywhere. The question is, why is it the fact that Sweden has 5.6% of the male population that smokes, compared to, for example, Norway, Denmark, and the rest of Europe, where you have 16, 17% that smoke. Well, thank you. The question is, why did we succeed in that respect, with smoking rates going down? Well, I think the important thing is that, well, here you see the slide in front of you.
Anders, yes, please give your running commentary as the slides. We'll flip through it, and you can provide.
So you see Sweden is on 5.6%, and the average in Europe is about 23, 24%, something like that, in the European Union. And we have, the question is, why did we succeed? Could we have the next slide, please? And here you see the vaping and nicotine pouches and snus. It's about 17 or about 20% of the population that does use snus every day. But the smoking rate is 5% or 5.6% of the men. Actually, in Sweden, there are more women that smoke than men, statistically. Could we have the next slide, please? And here we have the deaths in lung cancer, where we are the absolute lowest in European Union, and we are lower than the average of the European Union. And again, I mean, about the same percent of the men in Sweden use tobacco or nicotine in some form. It's just that they don't smoke. Could we have the next slide, please? Well, I mean, the first thing is that the government of the time, or different governments, have made smoking more difficult. And you know, if you go back to the 80s, when I was a medical student, everybody smoked. I mean, the head physician smoked. Everybody smoked. In the medical association, you smoked in the meetings. It was like that. And the question is, why is it the government's made it more difficult to smoke? Absolutely, but it's not that. It's just that we have alternatives. That's the important thing, I think, and that's what differs Sweden from many other countries. There are no alternatives, or the alternatives are being talked about in a very aggressive way. We can have the next slide, please. Yeah, I think it's very important to have alternatives. You know, snus is a thing which is moist and that has been around in Sweden for at least 100 years. It used to be a working class issue, and in the 70s, really, it started to become, you know, especially when you have the pouches, it became it traveled up in the classes, as it were. And it became an important thing for people that didn't want to smoke in the workplace, and they had an alternative. And as we have seen from the photos, we use nicotine about the same amount as in the rest of the European Union. It's just that we have much less deaths from smoking. As a matter of fact, the Smoke Commission, the Snus Commission, where I'm the chairperson, when I was approached by a public affairs company in Sweden, and they asked me if I could talk about snus. I don't use snus myself, you know, and I was a bit skeptical, to tell you the truth. But as I said, the two things. I mean, you know, one, I have to choose my collaborators, and secondly, the people that pay our work should not have any influence in what we produce or what we say. And I got a yes on both, so I decided I called some people that were important when it comes to smoking and snus and public affairs in Sweden. And what we did is that we have talked about snus, and we've only used open statistics, only the World Health Organization or statistics from the European Union, nothing else. No, there are no secrets. And we only tell people, only tell the world what is statistically true. We don't have any way of, we don't mix, the statistics, we don't change the statistics, we don't do anything but produce and tell people the reality. And I think that's important. You have to give people the chance to become smoke-free. And to some extent, we have succeeded in Sweden. It's not because of us, it's not because of me, but because of the way we have an alternative. And I think that the important issue here is to find an alternative to traditional cigarette smoking. And I think that we were lucky to have snus that was something that was accepted by basically everybody. And we have seen that snus does really save lives. If we compare the rest of the European Union to Sweden, we see that there are about 250,000 deaths per year that would be avoided if they would smoke and use snus as we do in Sweden. So I mean, it's quite important, And for example, I was in Norway, in Oslo. I met the Health Committee of Parliament there, and the first minister spoke, and then the Cancer Foundation, then people like I had the chance to intervene. And the Cancer Foundation in Norway said that there are 6,000 people that die from lung cancer each year in Norway. 6,000. And I thought it sounded a bit much. So I looked in my telephone for the Swedish figures. I looked at the Cancer Foundation in Sweden, and I looked at the figures there. We have a population which is 90% larger than the Norwegians. We should have about 11,000 or 12,000 deaths per year. And we have 5,200. We have about half the number of deaths that Norway has. The question is, why is that? Well, the reason is that you use tobacco, but you don't use cigarettes. And I think the important thing here is to find an alternative to cigarette smoking, be that vaping, be that snus, be that heat not burn, be that any other thing that could be patented and come up with the industry. And I think the important thing is that I think that I want to quote Derek here. We have to be mindful of the fact that there are 1 billion smokers in the world, and half of them will die from smoking. And if we want to save their lives, which I think we should as doctors, we should help them to quit. And to help them to quit with all the resources that we have in healthcare, we don't have the means really to quit. But we have to give them alternatives. And if they can get the daily nicotine from other sources than smoking, that's fine, because it doesn't kill you. You can live, you die from smoking, but you can live with the snus or something else like that. So I think it's important to tell the people, it's important to show statistically what is important. And it's very, very, you have to be truthful. You have to say the proper things, and you have to give them alternatives. I think that we have succeeded in that sense in Sweden, giving people an alternative. We had an alternative already. And we are trying to get the World Health Organization, the European Union, to accept the fact that alternatives are important. And so far we have wet the stone, but we haven't really made it fall apart yet. We're working on that.
Anders, thank you very much. A few questions, if we may, and thank you for investing your morning and helping the tobacco harm reduction debate here in Joburg. Now, Sweden is clearly the world leader in pushing down their own smoking prevalence, but it seems as if Swedes themselves are not celebrating this fact. And it's because it's been a public health revolution, we should all be on the mountaintop shouting victory and looking at Sweden as the best case practice. Could you tell us and explain to us why in Sweden it has not been accepted as a great public health advance? And then secondly, at the EU level, alternative products like snus, and even in most countries, oral nicotine pouches as used in Sweden, is still banned. Why is there this kind of non-recognition of the magnificent efforts in Sweden?
I think the issue is that the previous government was against harm reduction when it came to tobacco. We have accepted harm reduction when it comes to intravenous drug abuse, for example, or when it comes to taxes on alcohol. We tax hard liquor much higher per unit of alcohol than we tax wine and beer. So we have accepted harm reduction in that sense, but we have not accepted it in tobacco. Parliament, the majority of Parliament was, prior to the latest election, was pro harm reduction, but the government was not. Today we have a different government. We haven't seen them yet, what they want to do. They should, according to me, they should work with the majority in Parliament, which is pro harm reduction. The problem is that with their health authorities is that they are full of activists that see that anything in terms of harm reduction gives you a dependence. You're dependent upon a tobacco product. You shouldn't be dependent upon that. You shouldn't use any kind of tobacco whatsoever. That's their line. And we are trying to say that, if people cannot stop smoking, why don't give them an alternative, which doesn't harm your health? So we are pushing the government in that sense. Trying to get them to, and I hope that they will do that. They will speak to the European Union. They will speak to the World Health Organization, but we haven't seen it yet.
Thank you, Anders. Jose has a question.
Hi, Anders. My question is the notion that 350,000 deaths could have been prevented if snus was used more widely in Europe. What is being done about that?
Nothing.
Because that's a huge figure. Shouldn't it be something that would require a commission to look into how we got it so wrong, so that we don't get it wrong as we go forward? Because when you look at the challenges that we have with other alternatives, it's the same challenges that snus had. And it's something that, given in retrospect, that we know that lives could have been saved. As you've just illustrated the issue of the lung cancer between Norway and Sweden, can't we use that to say we need to have a commission where the WHO should be compelled to look into its own behavior, explain how it came to promoting the banning of snus, when we look back, there are these benefits, not on the basis of trying to find fault with people, but on the basis of ensuring that we don't make the same mistakes going forward. Because we're doing the very same mistakes that were done with snus with other non-combustible alternatives.
I think you're right, and we have tried to push the European Union in that direction. The problem is, European Union has a program called Europe Beats Cancer, and in that field we have written to the European Union and said that if you want to do something about cancer, you could start with smoking, because that obviously gives 250,000 per year that die from in lung cancer or smoking related diseases that wouldn't die if they use something else. And we are trying to push, as it were, to influence the powers that be in that direction. But so far, they are resistant. Because, again, the people that give them advice are people that do want everything. We should live good Christian lives, as it were. You know, we should be happy and we should engage in anything that is untoward health-wise.
Thank you very much on this. We are especially grateful for you investing your time this morning on our Tobacco Harm Reduction Summit here in Joburg. Just one last question before we let you go, please. You were also the head of a commission looking at various issues within Sweden, such as access to mental health institutions and also on HIV/AIDS. You were also very vocal when the Swedish government had a slightly alternative view on the COVID vaccine development and COVID prevention and control. What is it about Sweden that we can transport to other and apply in other countries, where you seem to be fearless and independent in thought when you set about preventing and controlling non-communicable disease? What can we take from the Swedish recipe and apply in other countries?
Well, I think that the important thing is to try to tell people the truth. I mean, you know, it's simple as that. Give them alternatives and tell them what the alternative is. If they use that, they will certainly die, or half of them will die. If they use something else, they will not die. It gives them the same intake of nicotine in this case. And I think that is the tradition. And we it's just that when it comes to tobacco, you know, everybody who works in the health authorities, they do remember the days when the tobacco industry died. And I know it too, because I've seen that. But the thing is that we see that it's more important to save lives today than to remember what they did 50 years ago. And again, I think that it's important to remember that we can save lives. I think that Derek has a great point there. You know, we can save lives if we give people alternatives to smoking.
Anders, thank you so much. I think that was a fantastic way to say thank you and goodbye to you, is that other governments like the Swedish government has, just tell the truth, especially to make sure that you communicate risk truthfully so that your consumers in that country can make wise choices. We thank you very much for your input. Any last words from you, Anders?
No, I just want to say that you know, the New England Journal of Medicine had an article a couple of years ago where they went through a number of health issues, and I quote directly from the article. It says that there is no disease burden attached to snus, and I think you have to accept the fact that snus doesn't give you cancer. You can live with that. And again, I mean, you know, we have that alternative in Sweden. You have other alternatives. So I think we should give people the alternatives and tell them the health risks with the different choices.
Anders, thank you very much indeed. With that, for our on-site participants, we might just have a short power interruption in the next couple of minutes, but we will carry on with our program. But at this stage, we say thank you to Anders and Derek, and thank you for joining into our summit this morning. While we wait for the power, can we just show the Swedish video?
I would wait until the power outage is finished,
Okay,
and then we'll
fine.
show the video.
Fine,
Yeah, let's take a 5-10 minute break.
fine. We'll take a 5-minute break, and then when we come back, we'll ask Dr. Josilet Lapi for his remarks. Thank you.
Sweden, the land of the lowest smoking rates by far in the whole of the developed world. So low that this year in 2023, it is set to become, according to official criteria, smoke-free. It's a goal that countries around the globe are aspiring to achieve by 2040. Most are on track to miss this target, but Sweden will smash it by a staggering 17 years. In doing so, it will become the world's first nation that once smoked heavily to give up cigarettes. Sweden's smoking rate just 15 years ago was more than 150% higher than it is today. The Swedes have shown us the way to be safer and healthier, just like they did when they not only invented the 3-point seatbelt, but donated it to every car manufacturer in the world for free. The seatbelt has saved well over 1 million lives since a Volvo engineer came up with the idea in 1959. The Swedes have also helped to turn South Africa into a better and safer place for all as a strong voice opposing the apartheid regime, and our Rainbow Nation thanks them today. Sweden's latest public health miracle could save millions of lives across the African continent in the next decade alone. You see, the Swedes have now effectively wiped out cigarette smoking by developing a specific policy formula that makes alternatives more accessible, more acceptable, and more affordable than cigarettes to consumers. The results speak for themselves. Swedes have long used education, tobacco control measures, and snus to keep smoking rates down. But the introduction of modern tobacco-free alternatives, vaping in 2015, and next-generation nicotine pouches which followed in 2018 turbocharged the smoking decline. In the last decade, smoking rates in Sweden have fallen by an astonishing 55%. South Africa's smoking rates are more than 5 times higher than Sweden's because Mzansi has a less supportive policy approach to cigarette alternatives. Compared to the rest of the European Union, Sweden has 44 fewer tobacco-related deaths, a cancer rate that is 41% lower, and 38% fewer deaths attributable to any cancer. If every other country in the EU followed Sweden's example, up to 3.5 million European early deaths would be prevented in just 1 decade. Yet South Africa is in danger of going in the opposite direction. The new tobacco control bill seeks to treat vapes and other nicotine alternatives just as harshly as much more harmful combustible cigarettes. The chance to save millions of lives by following Sweden's example will be lost. World-renowned public health experts agree.
The secret behind Sweden's success to go smoke-free is they've embraced harm reduction strategies. They've properly regulated new non-combustible nicotine alternatives, and they've been open to help adult smokers find a fire escape.
I think we have the answer already. Tell the world about the Swedish experience and the mixture of pros and cons that we have had that have been helping people to leave cigarettes and get into something else. It's important for the governments to tell the consumers that if you need your daily nicotine, use this instead of the cigarettes.
And this is Sweden's gift to global public health, and why the message to South Africa when it comes to smoking is quit like Sweden. Smoke-free Sweden 2023.
Thank you so much. With our Swedish giant still behind us, Anders, I now ask Gossi to address the summit. Dr. Gossi Lepla, please.
Thank you, Dylan. It's a bit of a challenge given the 2 speakers that went before me, and that for a rare moment, I don't know what to say because they've said it all. But I guess it might be easier because I was asked to speak about the HIV experience in the country. And there are lots of parallels with that situation. I became a chair of the South African Medical Association in 2001. And we had challenging policies that had been implemented in 2000 of no treatment policy for people living with HIV and AIDS. Now, as the chair of the association, what I came into was a world where our hospitals were being turned into hospices. Most of the medical wards were full. Patients were overflowing into the surgical wards. And the pandemic was paralyzing the hospital system. Colleagues were depressed. People were dying. We ran HIV clinics where people came for palliative care, basically. They were palliative care clinics. The medical profession was indifferent to the challenges of society. The Medical Association was silent on this issue. And I took it up as one of the biggest challenges that we faced as a society. And as a chair of the association, I dragged the medical association into dealing with HIV and AIDS. They were indifferent. They wouldn't even support HIV becoming a notifiable illness. There was a notion where, the majority of the association was the majority of the members were white, as the majority of doctors were white, and they viewed HIV as a gay and black problem. It's not a problem of society, so they were indifferent. So they were dragged into the HIV debacle. Whatever the big challenges around HIV, stigma was an issue. And when I talk about stigma, I'm not talking about just stigma in the population, where people had to hide if they had HIV. If you had a member of the family that was infected, those members should not come out, not to the family, not to the public, and they would die silently. We had funerals almost every week. We even had to change our patterns, where you now didn't go to all funerals, because otherwise all you'd be doing would be going to funerals. You now had to select. They had to be close to you for you to be attending those funerals. So stigma was a big problem. But the stigma was also in the healthcare system, where if you were a mother, a potential mother, a pregnant woman that was HIV positive, you were isolated, you were treated like that. The hospital staff would be whispering about your condition. You'd not be treated like other people would be treated. You were a pariah. So it was a real disaster that we were facing. Then you had Zaki Ahmad start the treatment action campaign, where he was a young man, an adult living with HIV and AIDS, who was also gay, and he had medical aid, and he decided he's not going to take treatment because the majority of the people he knew were not on treatment and were dying around him. I went to go and see him and say, Zaki, don't be a dead hero, is not a useful hero. And he said, he stuck to his guns. So he said, if poor people can't be treated, not interested. So we'll go back. The long story short, a few days after I went to see Zaki, Nelson Mandela called me and I went to go and see him. He also went to see Zaki, got the same story. And he asked me, what are we going to do? And I said, well, you get the money and I'll come up with a treatment plan. And I sat with him. He said, what is the biggest way in which I could contribute to deal with stigma? With your profile, you can deal with stigma. That's why he came out, disclosed that his son was living with HIV, and the rest becomes his to organize the money. And we put the first money into the public healthcare system to provide ARVs. The key challenges in dealing with HIV that came up was preventative measures were being stopped because of the concern about youth. You remember there was a program called Love Life, which was going to promote condoms amongst youth. And they were told, if you tell them about condoms, you're encouraging them to have sex. So we had challenges. You had money from USAID, which is really one of the good things that President Bush did was helpful. But even in the early days, you couldn't use their money to buy condoms. I don't know if you remember. And we had to overcome those issues and say, we got to protect children. But people wanted to say that by providing condoms in school, education to children, you're encouraging to have sex. So there's this youth mirage that comes up on these issues. And you'll find that even when you come to tobacco, the concern about vapes is about youth uptake. So we also have the youth mirage that comes into tobacco control. And that becomes a challenge. And what we've seen is that if you empower youth with information, the majority of them will make informed decisions and they'll protect themselves. But the problem is clear, credible information. If you listen to Anders from the Swedish experience, their way of life is to give the population truthful information. And the population usually will make better decisions with their lives. But once you get into subterfuge and you start lying about things, you create confusion in society. If you go back to HIV and AIDS, when ARVs were introduced, we had lies about how toxic they were. And ARVs of the time were not without their side effects, lipodystrophy, etc., etc. But what we informed people was that it's a choice, without ARVs, prepare for the funeral. With ARVs and the side effects, you can live. And 20 years later, 2001, 22 years later, there are people that are living now that would have been dead within 2 years of 2001. So many lives were saved, but it's not like ARVs are without side effects, but basically they reduce harm. So the upside of ARVs is much, much better than the downside of ARVs. But we have to convince our government on those issues. And part of the problem that we have in society is that you have people that are in high positions. And in societies like South Africa, we've been disempowered, where we defer to authorities to help us make decisions. So when authorities start to lie, it has a negative impact on society. In the height of the HIV battles, I had colleagues that would come to me and say, if the president of the country says this, there must be something that he knows that we don't know. There's some medical doctors. Some of them were professors. Because things are being said by influential people. And we have this good faith arrangement with our leaders. And I guess maybe it comes from religious indoctrination. And we defer to authority. But when authorities begin to be economical with the truth, it becomes harmful to society. And that was the challenge that was faced with HIV and AIDS. So you'll see the challenges where those in authority are on the wrong side of truth. And that creates challenges for society, where the youth issue becomes used as an excuse. Because nobody was saying adults should not use condoms, adults should not use ARVs. There were concerns about youth uptake of sex, which they were doing more than elderly people anyway. So that's the irony. Because as they say, when you're a youth, you do it 3 times a day. When you're older, you try weekly. Weekly as in terms of once a week, and with time you try weekly as in you do a feeble effort. But that's something to be discussed at some other time. So really the people that are sexually active were the ones that were being prevented from having credible information about making proper decisions about their sex lives. You come to tobacco, we have the same issue. Or people that may be the ones that are at the danger of taking up a nicotine habit, not being given truthful information about the different ways of getting your nicotine and what the risk continuum is with the different ways of taking nicotine. And the key issue when you come to tobacco is combustion and non-combustion. And that's the key issue. So you'll see that in Sweden, they talk about the fourth slide said smoke-free. I'm an advocate, I'm an African. So we understand that smoke comes from many things. You boil water, you see smoke. You vape, we see smoke. You use a heat not burn, we see smoke. You use a combustible cigarette, we see smoke. So when you say smoke-free, you freak us out because you think one of those authorities that is lying about things that are patently obvious, that there's something that we can see. And maybe we're different from Europeans who are saying, they can look at a smoke and know that this is a harmful smoke, that one is not a harmful smoke. We don't have those abilities. Smoke is smoke. So that's why, from my side, I prefer to talk about combustion and non-combustion, because that is pretty clear. And whether, in Sweden, they are correct to say smokeless because there's no smoke of any nature. There's no aerosol produced by snus. That's a smokeless product. We've always had snuff here. We call it smokeless. So let's not come with a smoke screen where we call other things that produce smoke smokeless. What we need to do is not to be economical with the truth and tell people that not all smokes are the same. The risk and the different things that you see are different. If you have smoke of Musiwa Tunya in Victoria Falls, it's just water vapor. Do not fear. If you have smoke from an e-cigarette, let's talk about what is in that aerosol, the constituents of that aerosol. Let's compare it with the dangerous weapon of combustible cigarettes. Let's compare it with the smoke that comes from a combustible cigarette and say, oh, how harmful is it? Is there any improvement? And as has been clarified, when you talk about harmful constituents, the scientific literature that measures the toxicants that tell you that there's more or less of this toxicant, some of them are eliminated, so that we educate people. So going back to the HIV thing, you had to educate people. You know, there was a time where there was an issue of, oh, Black people are promiscuous, that's why they're having a lot of HIV and AIDS. When the issue was not promiscuity, when the issue was the sexual networks that you'd be in. You know, you could be a faithful person in a relationship. You have one partner, but your partner has 3 other partners, and the 3 other partners have 27 other partners. So you are in a network where you can be infected. So it's not about promiscuity, it's about multiple partners. Reducing multiple partners will reduce your risk. So people need to understand, if you can't restrain yourself from multiple partners, at least put it in a sock. It might be better. So we promote condoms, we promote male and female condoms, you know, and we get to a point where you educate people so that they can make informed decisions. People got to realize that, you know, the biblical notion that sex is only for procreation, some people use sex for recreation, you know, and that's the reality of life. So how do we ensure that when you recreate, you do not die? We give you credible information in terms of how you can protect yourself. You know, morning after pills have come in. So strides are being made even in HIV, where people need to be taught that if this is how you behave, this is your risk profile. How can you reduce your risk of contracting HIV given what you can do? Now, when it comes to harm reduction, people come and think this is a foreign concept, Dylan. They don't know what you're talking about. Harm reduction is an everyday phenomenon. It's what we do in all our lives. You know, when you come and you're crossing Rivonia Road, if you choose to cross it at a marked pedestrian crossing, you're reducing harm to yourself. If you just jaywalk across, you are not reducing harm to yourself. So that's a harm reduction strategy. You walk to the light, you wait for the green light that's flashing a green man, and then you walk, you're reducing harm to yourself. If you're walking whether it's green, red, and you cross the street anywhere, you are not mitigating properly for the risk of being run over by a car. So harm reduction is everywhere in our lives. If you have an abusive husband, you know that when he comes drunk, you go sleep with the neighbors. He must get to the point where he becomes comatose so he can't harm you. And those are harm reduction strategies. Now, the common thing that probably we should be thinking about as South Africans in terms of harm reduction, there are 2 things that most people can live without. Some can live without both, some can live without one. It's government and religion. But when you look at societies, most harm in our societies is caused by governments and religion. But we can't live without them. So what we need to be talking about is how do we reduce the harm that is caused by governments? You know, we then try and come up with democracies, elections, limitation of terms. Those are strategies to try and reduce harm associated with governments. I mean, corruption is endemic to new governments. When you get a government that is formed, not on the basis that you are the king, you are the bloodline, but it's on the basis of that you campaigned and you are funded by crooked rich friends. Corruption is embedded in our democracies. But we can't do without government. So what we have to talk about is how do we reduce the harm associated with democracies? Corruption is embedded in everything, and we can't eradicate corruption. And you know, so sometimes people think corruption is when somebody steals $1 billion and there's no money for food. But when you have a vice chancellor appoint a nephew or a niece to medical school that did not meet the criteria. That's corruption. So how do we reduce these issues of corruption? Because we can't eliminate having a vice chancellor that has discretionary powers to use, because it might be used to lift up somebody who would have had no chance of coming into medical school, not relatives. So that power still has to be given, but we've got to mitigate about it being abused. You know, when we talk about corruption, which probably would illustrate better what harm reduction is, because we live with it. We're talking about strategies to reduce the levels of harm associated with government. When you see what happened at municipal level, where we are in one of the biggest cities in the continent, and every other month we are without a mayor. How do we prevent that? So we need to look at measures of how we prevent corruption in that environment, because we can't eradicate it. So the issues of mayors in Gauteng are like underwear, they change every day. It's because of corruption. And we've got to look at strategies of how we kept that so that we could have a stable society. But we can't eradicate it. You know, I'm from the health sector, where part of the problem with our health resources is the levels of corruption have not been reduced. So when you have something that you could buy for 1 rand, you now pay 100 rands for it. So we're not saying there should be no middlemen, because if you have a government, you're going to have middlemen. Say, but if it costs 1 rand, at least charge us 1 rand 50, not 100 rands. So you're reducing harm. You're not going to eliminate it completely. I come to religion, sex scandals, people, poor people, taking their own money, giving it to religious leaders, and they starve. How do we ensure that religions don't harm people? So we've got to get into there and educate people. But you know, if there's a God out there, this person that walks on 2 feet like you can't be a representative of God. So why are you giving your money to them? Maybe what you should be doing with your money is to do good in society. Then you're doing God's will. And that way we could begin to reduce harm related with religions. Now, for those of us that are in tobacco harm reduction, the issue of the youth mirage is something that we should take up seriously, because people will not talk about the things that should concern us. They are not concerned about saving lives. Because if we had an adult conversation, and we said adults who use combustible cigarettes, 50% of them will be killed by the product that they use. And we said, these are not smokers. These are people who smoke. And we humanize them. And we begin to see them as humans. If you go back to HIV, there were people where people were being called, oh, he's got AIDS. Oh, she's got this. But once the terminology changed, because they stood up and they said, we are people living with HIV, it became a completely different paradigm. They took responsibility for their lives. They earned respect from the rest of society. So those that are nicotine dependent should stop describing themselves as smokers. They should begin to describe themselves as people who smoke, people who use nicotine. Because once you do that, you become visible. Right now, people who smoke are not sin. And people think they can make decisions for them without them, and decisions that are adverse to their own reality. But having said that, we should not be unmindful of the youth noise, because it's legitimate noise. There'll always be concern about youth uptake. But what we need to do is to be rational about this, to say, let's give the people credible information. But for adult smokers, the non-combustible alternatives are highly recommended. That is why governments like the UK are giving their citizens vapes in their national health system. That is why governments like Japan have allowed heat-not-ban to come into their environments with tremendous benefits, where the use of combustibles has come down and health benefits are being derived from that. And then we need to have an open debate about how we prevent youth uptake. What should not be allowed is for us to continue lying about the health benefits of non-combustibles for adult smokers. And it all becomes about potential youth uptake. Because it's then like people who smoke don't matter. Let them die, they don't matter. We just have this issue about worrying about the youth. And the youth of today, if they are given credible information, they will make informed choices. The youth of today, if they are told the truth, they'll continue to innovate so that out there we'll have even better products than what we see now. If they are told the truth that the problem is combustion, greater alternatives will be in the horizon. The last thing I would like to say is that, as has been said by Derek, the FCTC is a great framework for combustible cigarettes. And it is not something to be thrown away. But we need to create a new appendix for how we regulate non-combustibles. That framework cannot be applied to products that did not exist when the framework was formed. None of the people that created the FCTC have any powers of prophecy. So they didn't see what was coming up. So let us stop pretending that what was appropriate then would be appropriate now. It's like using telecommunications regulations that were written for the fixed telephone line, and you're trying to apply them to the new world of cell phones. It would not be applicable. You got to create a framework that is applicable to the reality of today. We cannot keep our heads in the sand. The world of 2023 is not the same as the world of 2003 when the convention, the FCTC, was signed. It will remain relevant for a long time, but we need new frameworks, new regulations for new products, so that as a society, we do not become anti-progress. Lastly, I'll talk about the issue of trust. You know, I've spoken to a lot of people in the industry, and they were worried about how do we get the people to trust us? I said, forget it. You know, what I like about trust is what's written on American currency. I always carry a US dollar with me. For the sake of time, I won't take it out. And what's written on it is, in God, we trust. If you're not God, don't ask me to trust you. But sadly, what is happening today is that it is not only the industry that is not trusted. What pains me as a doctor is that even public health can now no longer be trusted. I thank you all.
Thank you very much, Dr. Detlapi. And on this note, we are privileged to have Joseph Mageru here from Kenya and Kurt Yo from South Africa. And I'll ask Joseph first for his remarks, and then Kurt for your remarks. And then we'll have a short panel session at the end to follow up on what Khosi said, Anders, and so on. Joseph, please.
Good morning.
You can start,
Can you
Joseph.
hear me?
Yes, we can.
I'll speak CASA. So CASA aims to promote innovative solutions for tobacco smoking cessations in Africa, while remaining committed to and supporting tobacco, especially Article 14 of the WHO framework that serves as a platform for advocating and promoting all innovative solutions for ending smoking. Smokers are often the silent victims of the tobacco control campaign. I know this because I was one of those who tried to give up smoking, but failed several times due to a lack of genuine alternatives. Eventually, I was able to quit. Okay, can you hear me?
Joseph,
Yes,
there's a bit of a lag. Can we just try once more?
Yeah, so I would say the current strategy is to classify vapes and all pouches as tobacco products and subject them to the same high taxes. This is the direct opposite of what has been so successful in Sweden, where smoking rates are less than half what they are in Kenya. The Swedes have shown us that the harm reduction approach can greatly reduce smoking rates, and they've done this by using different nicotine products and being clear about the different risk levels, each of them. They are now on the track to be the first smoke-free country, and this is what CASA intends to do in Africa. But this is not going to happen in our current strategy, which is simply not working for smokers, for example. As CASA found when we conducted an extensive consumer survey last year, we found that more than a third of smokers who've tried to quit have failed in doing so. 9 out of 10 of those surveyed believe that vapes and pouches would give them the best chance to succeed in quitting. But almost as many, 3 out of 4 think these products are too expensive or too difficult to get a hold of. The survey results align very closely with the Swedish experience in terms of preferences for alternative. Their message is simple: make smokers and they will give up traditional combustible cigarettes. Alternative nicotine products are significantly less harmful than cigarettes, so can put smokers on a path to quitting faster than a quit or die approach. Nicotine pouches offer a particularly relevant solution in Kenya, where there's a long tradition of people using oral stimulants. Perhaps unsurprisingly, almost 3 out of 4 people in our survey said that nicotine pouches would be their preferred method of quitting. But yet still, the government insists that they be regulated the same as far more harmful cigarettes. The end result of this policy is that there is a demand for cheaper products that are often unregulated and potentially dangerous for the market. It's now very common to see Kenyans using electronic cigarettes and pouches that are illicit. They've evaded taxes and do not come from authorized sources. The potential of harm from such products is obvious. It seems clear that if we want a smoke-free Kenya, we should learn from lessons coming from countries such as Sweden. We need evidence-based policymaking, as has been employed in Sweden, and we need better education and reduced harm options available to smokers, as they have provided in Sweden. Thank you.
Thank you very much, Joseph. Now we invite Kurt Yo to make some comments from the South African consumer perspective. Please, Kurt.
Good morning, all. If you think Course is going to have a hard time with being speechless, I think I'm really going to struggle. Yeah, wonderful presentation by everybody. So in my former life, working in corporate, my manager would have asked me during our performance reviews, where do you see yourself in 10 years? I can safely say it wasn't this. A big thank you to African Harm Reduction Alliance, Dr. Himon, Dr. Letlalpe, and Jessica, and the rest of the team for putting together a much needed platform that has formed a part of my life, a significant part of my life for the last nearly 10 years now. It's also a great honor to meet you guys. Huge fan of your work. Thank you very much. In my view, we have lost on the real mission, and one of the biggest and established threats that face society with regards to NCDs, non-communicable diseases, reduce smoking-related deaths and disease. According to the World Health Organization, over 80% of the world's 1.3 billion tobacco users live in low and middle income countries. Tobacco kills over 8 million people each year, 7 million from direct use and 1.2 million from secondhand exposure. In South Africa, reports of tobacco-related disease deaths vary from 20 to 40,000 per annum. That's anywhere from 77 to 109 souls lost every day. The discrepancies in this local mortality figures underlines my previous statement, and I think it also talks to what Corsi was saying in terms of accurate and free information. It's vital. Yet we see a disproportionate amount of coverage on the technology and a range of products, vapes, that have scientifically been proven to significantly less harmful than combustible tobacco, the most widely used product for smoking cessation, and according to the Cochrane Systematic Review, which has been looking at this particular question for a decade, the most effective smoking cessation tool. In other parts of the world, rates have plateaued, but in South Africa has seen an increase under the current traditional tobacco control strategies. It is time for a rethink. It's time to clear the room of smoke, there's a pun intended, and address the elephant in the room. Can these novel products bring us back to the actual mission? Next slide, please, Jessica. I must apologize. This slide in my testimony always chokes me up. You can see it starting already. So I do apologize. I am a father, I'm a husband, a brother, and an uncle. I'm not a doctor, a scientist, nor a researcher. I'm a guy that lived through so many what people have lived through, just took stock and tried to make a difference. I smoked for 20 years. At the height of my addiction, I smoked 40 cigarettes a day. It's 2 packs. It was the death of my father, a lifelong smoker. A day before our planned wedding, my wife, a pediatrician, that ultimately convinced me to quit smoking. It was hard. And I failed multiple times. I recited the fact that I would eventually quit, much like my father did, through death. I tried those other cigarettes, the ones with the little light in the front, the twist, but everything didn't work. But yeah, it starts getting a bit happier. It was a chance meeting in my office parking lot where I met a person selling vaping products and e-liquids out of the boot of his car. There was no vape shops in those days. That chance meeting changed my life. So, still desperate, wanting to quit, I took the leap and purchased an open tank, regulated device with 12 milligrams of imported e-liquid. Within 3 days, I quit smoking and have been smoke-free for almost 10 years. Fast forward 2 years, I left my corporate life and started a small vape shop, which was based on the success of helping colleagues in switching. During this time, small independent vape businesses began to appear, particularly in Johannesburg, and I would buy products on behalf of my colleagues and friends and help them switch. In 2017, after negative reports started making the headlines, which did not match my experiences, my co-founder, a small vape shop owner in Durban, and I formed Vaping Saved My Life. Now it gets worse again. Smoking wasn't finished with me. My biggest failure as a THR activist was not being able to convince my mother to stop smoking or switching. On the 27th of September, 2019, on our wedding anniversary, my mother became another smoking statistic. Sorry, guys. We said our final goodbyes on my mother's birthday, my birthday. And those closest to me now know I don't celebrate that day anymore. My son, Ronan, never met his grandfather and has very little memory of his grandmother. This is the real tragedy of smoking, the impact it has on families. At 47, I am the 4th oldest person in my father's family. I only have 1 uncle and 2 older cousins who have also lost their parents. When they speak, sorry guys, really sorry.
No problem.
When we speak of protecting future generations, does this include kids like Rowan? This is why I wake up every morning, put on my activist armor, and face the disinformation beast. Families are picking up the pieces far too soon, and kids lose the kindness and wisdom of our older generation. What our older generation can offer. Next slide, please, Jessica. As mentioned, in July 2017, VSML started as a Facebook page to collect testimonials from former smokers, now vapers. To date, we have collected 657 testimonials. In 2019, I moved the testimonial platform to VSML website as Facebook community standards was becoming a real challenge, and it's a challenge we face frequently. I have personally met many of the people that have posted these testimonials. Their stories and experiences echo mine, but few are heart-wrenching, especially those relating to those people that have overcome cancer and smoking-related diseases. I'm in no way suggesting that vaping cures cancer. What it did was offer a way out of the very thing that contributed to the disease when everything else failed. This is the metadata behind statistics. Listening, empathy, and understanding needs to come back to the forefront. Although testimonials will always be a cornerstone of the movement, it falls only a small part, or falls a part of the broad activities like petitions, surveys, engagements, combating misinformation on vaping. And in 2019, I decided to leave the commercial aspect of vaping and focus all my attention on activism. These voices must be heard, as they represent hundreds of thousands of South Africans and estimated 85 million vapers worldwide. They can no longer be the orphans in policy discussion, as they are the evidence. Next slide, please. I believe South Africa has failed to address smoking prevalence, and this slide demonstrates this. Even at the most basic level, we have failed to monitor the tobacco landscape from a user's perspective consistently. Until the first ever global adult tobacco survey in South Africa conducted in 2021, the country had never invested in a consistent monitoring methodology or tool that looks at tobacco use specifically. For example, in all 5 waves of the National Income Dynamics Study, only 5 questions are directed towards smoking in a 54-page questionnaire when searching for the words smoking, tobacco, or cigarettes. This is a complex issue with links to physical and mental health, social dynamics, and economic factors, affecting a quarter of our population directly. In my opinion, an inconsistent monitoring tool that is not South African-centric in a design robs us from getting a better understanding of the nicotine landscape. It is safe to say that the recent Global Adult Tobacco Survey of South Africa provided a rude awakening with figures last seen in the late 1990s. Let's hope that the South African Health Department sticks to its commitment that the GATS will be a consistent and ongoing monitoring tool. Let's look at specifically the GATS of 2021 and the data provided by South African Medical Research Council fact sheet, presented differently here. Vaping plays a small part of the nicotine landscape. Unfortunately, after multiple requests to access the data, I have been rejected, leaving many important questions unanswered. In this view, tobacco and e-cigarettes use in the cohort under the legal age, oh, sorry, I skipped there. Unfortunately, if we look at the tobacco use, is there a view of tobacco and e-cigarette use in the cohort under the legal age of 18? If so, why is this grouping of 15 to 24 applied? which is inconsistent with the tobacco laws of the country, and it doesn't really address the real concern of underage use. What percentage of these figures can be attributed to the consumption of illicit cigarettes? What percentage of the 2.2% of e-cigarette users had used traditional tobacco in their past? What percentage of the 4.2% of dual users is a smoking cessation attempt, and it captured at that point of transition? Were any of these questions asked during this particular survey? If not, why not? Looking at these figures, does this align with the disproportionate coverage of vaping in the country, especially regarding the youth? Make no mistake, as a parent, youth smoking, youth vaping, as well as other risky behaviors is a real concern. This deserves further studies and appropriate action, but not at the expense of adult smokers, or, sorry, Corsi, adults who happen to smoke. Who could benefit from safe alternatives? In my opinion, youth vaping is concentrated in a very specific small cohort of teens in high-income groups. This is not to say that there shouldn't be concern, but it does remove the focus from a greater percentage of underage smokers. We don't have the luxury seen in other parts of the world, which have recorded historical lows of smoking rates amongst the youth. We have a youth smoking issue that has escaped the attention of many. Next slide, please. I'm about to present a snippet of the results of something that we do every single year, the 2022 South African Vapers Survey. The iteration of this survey, and the annual is an annual activity since 2018, was made possible by a scholarship that the Knowledge Action Change awarded to me last year. The Tobacco Harm Reduction Scholarship has been invaluable in my vocation as an activist. I'm not going to dwell too much on these slides for the sake of time. However, it is important to explain the method and the limitations of the survey. The survey is aimed at a very specific cohort, current South African vapers. Therefore, these results will only reflect the part of the vaping landscape. This limitation exists due to the restrictions imposed on vaping-related posts on social media and the cost related to access to consumer databases. The survey consisted of 54 questions, most being selection and multiple choice. It was hosted on the VSML website using a purposely designed survey application, and it was promoted on the VSML's social media pages, in closed vaping groups and independent vape shops, and in last year's VapeCon. These limitations will also explain the underrepresentation of vapers under 18, based on age gates and restrictions in the areas where the survey was promoted. Therefore, this code is confined to current adult vapers that frequent dedicated vape shops and follow VSML and vaping posts in closed social groups. There's no surprise heavily based socioeconomic factors of the predominant vapor is a South African of white, full-time employed male over the age of 30, followed by white females in the same category. Based on the concentration of vape shops in Gauteng, Cape Town, and Durban, most of the respondents come from these locations. Unless there is some form of public-private partnership, as seen in other health interventions, it's unlikely that vaping will significantly impact smoking prevalence in South Africa. However, given the scale of smoking situation, it would be wise to expand the cessation toolkit, providing smokers with every opportunity to switch and eventually quit. Other more cost-effective reduced risk products, like nicotine pouches, could play a more significant role in South Africa. Next slide. In this cohort, specifically, switching had a desired effect of moving away from traditional tobacco. Again, based on the collection methodology, these figures may not represent the overall population experience. However, looking at these figures and knowing what the limitations of this particular cohort is, something could be said about the importance of community support and local vape shops in helping smokers migrate to vaping. Understanding these dynamics could be important. In past surveys, we asked if there had ever been previous attempts at cessation. In this particular survey, we attempted to get a better understanding. It is clear that there is a desire to quit, with most opting for a cold turkey approach. The questions were asked about the longest period of smoking abstinence achieved whilst using these methods. And these percentages are frightening. 20% indicated less than a week, 25% less than a month, and only 20.4% less than 6 months. Based on various studies, including the GATS, there's a desire expressed by smokers to quit. However, many fail due to the absence of services and support and the refusal of the role harm reduction could play. South Africa has yet to implement all of the guidelines stipulated in Article 14 of the World Health Organization's FCTC. This article speaks to services and support needed to help people quit smoking and was adopted at the fourth conference of the parties in 2010. Based on my own experiences and that of many vapers I've engaged with, reduction in nicotine strength was common. In this iteration of the survey, I wanted to explore the extent. It must be noted that it's purely based on preferred strength and it does not cater for device changes or the number of puffs taken. The milligram range between 0 and 6, where most vapers gravitate to over time. In the group indicated no change, which is 45.9%, 71% were in the 0 to 6 milligram range, with the majority using 3 milligrams. In the group indicating decrease, 57% moved down from a higher nicotine strength to the 0 to 6 milligram range, and 24 lowered within that range, so 6 to 3 or 3 to 0. 36% of the cohort that increased the nicotine strength moved into the realm generally seen in disposable vapes. Apart from the need to increase these nicotine strengths, factors such as convenience, cost, and even the current electricity crisis in South Africa, not being able to charge batteries, could explain why people are moving towards disposables. Next slide. This is not part of the survey, but it's linked to nicotine strength. As of the 1st of June 2023, an excise of R2.90 per mil, irrespective of the nicotine content, will be imposed in South Africa. This will move vapors in predictable ways, which I fear will do more harm than good. At the same time, do very little to dissuade the very population the excise intended to protect, our youth. Anecdotal evidence suggests that teens prefer small, disposable vapes containing very high nicotine levels. The most common is the 50 milligram variant found at most retail outlets, including petrol station forecourts. If an increase of R5.80 on the most used and widely accessible disposable vapes will have no impact in dissuading the youth. Competition in the space will increase, seeing some, if not all, of this tax absorbed by industry players to gain market share. Conversely, the excise will see adult vapors shift to undesirable areas, namely to the black market, back to smoking, or into higher nicotine strengths purely based on cost. This is particularly cruel given the stats presented previously. Adult vapors working down the nicotine strength ladder will face difficult choices. The preferred 3 milligram 120 ml locally produced e-liquid will see a plus 200% increase at the till. It is also a shame that Treasury turned its blind eye to the certain outcome that local manufacturers and small independent vape shops will face when the tax is implemented. The hypocrisy of President Ramaphosa's commitment to small enterprises and tackling unemployment to that of the Treasury's move to implement such a tax leaves me dumbfounded. The environmental impact of disposable vapes based on this market manipulation will become a far bigger concern. Based on 2 data points collected by VSML via testimonials and the survey, it is clear that flavors matter to adults. Both fruit and dessert flavors profile feature high, with tobacco flavors less so. 88.7% of adult tobaccos indicate that flavors are important in the survey. Flavor bans are a real concern, as it is inferred in the current tobacco and electronic delivery system bill now sitting before Parliament. The importance of flavors is well known in reduced risk strategies, not only in nicotine replacement therapies, but in sugar-free, fat-free products, as well as salt substitutes. Although plain variants exist in these products, most attempt to replicate the original flavor. Imagine a tobacco-flavored gum. Would you use it? Please note that the nicotine strengths on these packs are pretty much the same as where every vapor eventually gravitates to, between the 0 and 6 milligram range. I'd like to thank everybody for allowing me to present, and thank you so much.
Thank you. Thank you, Kurt, and especially the raw emotion with which you describe the journey of adult smokers or people who smoke, if we can use Jossie's way of describing this cohort in South Africa, people who smoke and people who vape, and their difficulty to gain access to accurate information, especially accurate information about products, and most importantly, what benefit it would hold for the health. So we've reached the last point of our summit, and we have at the panelist desk, we have Jossie and we have Kurt. I just want to make sure whether Joseph and Anders are still on, please.
Yes, they are. They're just
Yes.
coming.
Fine.
Yeah.
Hello, Anders. So now it's the chance to have, we'll have 10 minutes of panel discussion. Perhaps just the first question to Jossie. Jossie, you successfully campaigned for the HIV/AIDS patients, which was a small minority group, but an important group, to gain access to antiretroviral therapy in this country. You then, in your remarks, you compared that group with small minority groups in South Africa, like people who vape or people who have TB and smoke and don't get accurate information about the alternative. If you had to fight that battle again, how are you going to turn it around in South Africa now and gain access for these small minority groups of people who smoke, to give them the right information and chance to switch?
It's a difficult one. If you look at HIV and AIDS, it took a person who was living with HIV to stand up, organize people that were in a similar position, and create a group called the Treatment Action Campaign. It's fairly difficult because of the long period of stigmatization of people who smoke, to organize smokers into a group, people who smoke into a group. And no matter how educated they are, a lot of them that I've tried to organize are trying to quit. So they feel ashamed. There's a lot of issues of shame. And it takes me back to where, even in HIV, we went through that period where we saw people that were educated that would not take ARVs because everybody would know that they'd rather die than do that. So it's a difficult space. So coming from a medical background where it's science-based, one of the things that probably needs to be done is to have a more robust discussion about misinterpretation of data, misrepresentation of science like Ivali, and be able to record those things and just ensure that you don't just get retractions, that these things become etched in memories, and there should be investigations as to whether was this done deliberately to misinform, and there should be consequences for those professionals that acted unprofessionally. So I think that's something that for me, we should be able to explore. I worked in health regulation. I hope people who smoke would go to healthcare professionals and ask them what are the alternatives and report them if they are malpracticing. You know, when we went with HIV and AIDS, it came to a point where people living with HIV knew more about their disease than the doctors, and they educated their doctors as they went along. The doctors were willing to be educated at the time. We changed the issue where, you know, people should have access to treatment, etc. And maybe we need to get on the same brigade where people who smoke should be going to healthcare professionals, says what are the alternatives? And if the person gives you misinformation, report them to the regulator for the misinformation so that they're forced to get the education, so that we break the cycle of people embracing ignorance. I mean, if you look at our medical training, there's very little that we're taught about nicotine. And we practice from a basis of morality and ignorance rather than evidence-based practice based on science and knowledge when it comes to tobacco.
Jose, I'd like to come back to you on the health professional question, but first to Anders, please. Anders, you were the chair of a commission of inquiry into the capacity to treat mental health disease and problems in Sweden. I would like to know, and at the heart of that commission was the question of access to mental health care in Sweden. Are there any principles that you found in improving access to mental health care in Sweden that can be applied to tobacco harm reduction, especially against the background that we know that about 60 or 70% of mental health patients smoke? So they are the prime consumers that Curtis referred to that need to get the information to switch to less harmful products. But are there any principles that you found in that commission of inquiry report that can be translated and applied to tobacco harm reduction, please?
Well, I think the important thing is really to tell people the truth. You know, it's the same in psychiatric care as in when talking harm reduction and tobacco. You know, tell people the truth, and the fact that we as doctors do not want people to die unnecessarily. And what we're trying to do for the people that have difficulties with their mental health, I mean, we don't want them to die. We want them to have as happy lives as they can, and I think that the same goes for people that use combustible cigarettes. You know, we should try to help them to get away from the cigarettes and do something else. I mean, other ways of getting nicotine. And unfortunately, I mean, we haven't seen the happy faces of the Swedish government yet when it comes to the figures that Sweden has reached, but I think we will.
Thank you, Anders. There's a question online.
Yes, so for Anders, in Sweden, are nicotine pouches classified as tobacco products, consumer products, or food products?
To tell the truth, I really don't know. You know, I'm talking about the importance of people leaving cigarette smoking. I really don't know the difference between or the taxation issues. They're not my business at all. I'm not selling myself. I'm just advocating for a better life. So I'm sorry I can't answer the question.
Just a question then on health professionals. Jose mentioned that there seems to be many misperceptions amongst health professionals and even doctors, that in certain surveys it shows that up to 60% of doctors believe that nicotine, for instance, is carcinogenic or is linked to cancer, of which we know there's absolutely no evidence that this is the case. Why is there this kind of misperception amongst health professionals, especially doctors? I speak to Jose and Anders as recognized global medical leaders. Why the misperception and how can we fix it?
You know, Dylan, I'll give you something that is similar that you will relate to. ethics, that doctors know nothing about ethics. I mean, Anders has been chair of the World Medical Association. You've been CEO of the World Medical Association. And why is that? Because it's not taught in the curriculum. We think people will get it by osmosis. There's very little in the medical curriculum about nicotine. Where do we expect them to get that knowledge when it is not taught? And having just come from a WMA meeting, it has become patently clear to me that even about ethics, doctors don't know about ethics because ethics are not taught in medical schools. It's monkey see, monkey do, and you'll pick it up on the way. And so the knowledge that we have about nicotine is the evangelical message that we get from our professors to say to the patients, quit or die, and we move on. And there's nothing about, this is a problem. How do I help you? How do I move you to something? Even the same issue about people that have weight problems, people that are obese. Doctors are uneducated about matters of nutrition. They just tell you, go lose weight before we do the operation. Nobody's going to help you to say, how are you eating? How do you eat? What are the quantities? You can reduce the quantities on your table, and help you through. So it's based on the fact that it's not taught. And we think doctors are God, but what we are is dependent on the training we've received. Anything that we're not trained on, we do not know. We're not trained on nicotine. We know nothing about nicotine. We're not trained on ethics. We know nothing about ethics. So unless we put it into the curriculum, how do we expect them to know?
Anders, anything to add from your side?
Well, I mean, I agree first with what it says, and the fact is that the jury, as it were, is out, because there's always people that are going to claim that. I mean, including doctors, they're going to claim that nicotine gives you cancer, or nicotine is dangerous, or whatever, because they don't like the industry. I think we have to get back to that. They remember, or they were told that the representatives of the industry were not truthful 40 years ago, and they still believe it's the same thing today. And they don't accept the fact that they will let the people that smoke today die, because they don't really care. Unfortunately, we care.
Thank you, Anders.
So I think, Dylan, is the power of messaging. When you get, I've been African all my life, and I've had to get into training in medicine where it was an all-white thing. And the colleagues would look at me and be surprised that I'm just as human as them, that I have certain capabilities that they have, because they were taught that we are an inferior species without any basis, but that's what they were taught. So the issues of the strength of the industry can be trusted. Not that the industry didn't lie on essential issues, but that's all that is being put out there. So you have these challenges that we have in South Africa, where there were atrocities that were committed against us by previous generations of white people. And unless we openly talk about it, what happened then, and we're truthful about it, will perpetuate the environment of hostility between those of African descent and those of European descent. It does not mean atrocities were not done, but we need to engage what happened. How do we prevent it going forward? But how do we engage going forward? So the same thing needs to happen with the industry. We acknowledge that they did something wrong. Okay, so how do we ensure that they don't repeat those mistakes? How do we ensure that if they lied about the impact of tobacco and that it causes cancer, that we don't lie about other things, truthfulness about the benefits from vaccines? There was a study done where people thought coffee caused cancer because there was a high incidence of people that used to go for coffee breaks, until somehow found out that they go for coffee breaks, but during the coffee break, they smoke. So what was killing them was the smoke. and not the coffee that was causing cancer. So we have these casual associations that get made on issues. And you have challenges today where you have a paper, when you have a scientist say, you know, this is what I think, then you know that they are fibbing. Because science should not be about what you think. Science should be about, this is the evidence.
Thank you for that, Khosi. Question online.
Interesting online question about nicotine addiction. So the question is, in promoting these new alternative products as harm reduction alternatives, are we treating nicotine addiction or are we feeding it? Now, Anders, you did provide a written response to that. Would you mind just iterating your point verbally on camera? And then perhaps the panel would like to also answer that question from your point of view.
Yes, you know, I think we are giving people what they want, and we are giving people what they need. I mean, some people do need the kick that nicotine gives, and for the rest of us, it's not happening. But we can give something to them without danger to their health, and I think we should do that. You have to remember, you know, that it's nicotine and tobacco is much less harmless than, for example, than THC, you know, and things like that, you know. So I mean, you can on the one hand forbid tobacco, and on the second hand, you know, promote use of nicotine, of drugs, as it were. I think that's wrong. So I think we can help them get away from the deadly habit of smoking.
I think for me, to the person that asked the questions, I'll just give you a simple example. It's like saying, you know, when we create pedestrian crossings, are we feeding the behavior of crossing the street, or do we want to prevent people from crossing the street? The harm reduction is about things that people do, no matter what your values are. And how do you help them live with that and reduce the harm associated with that behavior? So we do the pedestrian crossing because people are going to cross the street. But we're saying, here's where it is safer to do it. So even on the issue of use of nicotine, people are going to use nicotine. And we're just saying there's a safer way of using it. Just like we all use sugar. Sugar gives you go, but there's a responsible way of using sugar, or sugar can kill you. You know, water is essential for what we do, but if you take it in too much doses, your brain will swell and you will die. But nobody's going to say, because you can do that, stop using water. And nobody's saying we're feeding the behavior of using water. This moral way of looking at life should stop. You know, I'm a doctor. You come to me, you're sick. All I do is to help you get better. And I'm not going to get into the era of stop doing this, stop doing that, stop doing. I give you information that if you do this, this is what you should expect. If you do this, this is what you should expect. If you want to mitigate against this, this is what you can do. This is what this is about. So this notion of we feeding the addiction, etc., that's an evangelical approach. And I'm not a pastor for a reason. I'm just a medical doctor. And it's to help people with decisions that they make and to give them credible information so that they can make informed decisions.
Thank you, Khosi. To Kurt and to Joseph, the World Health Organization subscribes to what the United Nations have said in their high-level Commission statement on non-communicable disease, that to prevent and control chronic disease, we need a whole of society, whole of government approach. Now, it strikes me that both of you have been very successful in building consumer networks. Joseph, you in Kenya, and Kurt, you in South Africa. And I know that you've been working together with global networks like INCO and the World Vaping Alliance as well. How can this be accelerated, and how can the consumer networks further be strengthened and enlarged so that the whole globe and all the vapors in the world can be serviced? Kurt, please.
I think it's that information that needs to be shared. But you know, we're standing as consumer advocates, as well as a lot of the people in the medical fraternity, are facing a war of disinformation and actors within that space that is actively discrediting, labeling it, stigma. And it's only when we start seeing reality catch up that I'm afraid this is going to be an ongoing battle. So it's always going to be about information, accurate information, backing it up with the evidence and the science. And we should never stop investigating in these areas. For example, the question that was asked online about nicotine addiction. What is nicotine addiction? What does it look like? Because nicotine addiction in the form of smoke means 1 in 2 people die prematurely. But that's the kind of information that's now fed into the ether, is that nicotine is the problem. Is it really the problem? If we consider that since 1983, we've been able to use nicotine replacement therapies quite easily and readily. And at this point in time, you can go into any pharmacy, go to a shelf and pick up a nicotine gum or nicotine spray without a prescription, without even a second look, and use that product. Is nicotine really a concern?
Fair point.
So I think that is the issue. We've got to keep pushing, keep informing, keep providing the evidence, and eventually reality will catch up. And I think Sweden is now that tipping point where we start seeing that harm reduction is a viable route. We've got to a point in this smoking pandemic, if we can call it, where we're seeing a plateauing. And now we need that next bit of innovation, and then the next bit of thrust to start eliminating combustion from this discussion. Nicotine, I don't see as an issue. Unless you ban the alternatives, then people's source of nicotine goes back to a far deadlier source. That's when it becomes an issue.
Thank you, Kurt. Joseph.
Yeah, thank you. I think for consumer organizations,
Joseph, we have a sound problem. Can you
I
just speak louder, please?
I'd recommend, Joseph, you type your question to me and I can read it out. Is it the question I already have about doctors?
comment. I think my sound has a problem. For now.
I'd recommend you type the question to me and I can read it out.
We can read it out, yes.
I've got another question in the meantime.
Okay,
while
yes.
Joseph does that. It's actually from Joseph, another one. And it's to Delon about education of doctors and potentially medical students. Does ADA plan to draft a doctor's guide to tobacco harm reduction to help educate them?
Thank you for the question. And it links to the point made by José that there isn't a standard ethics training all over the world for medical doctors. And in fact, in that space, the World Medical Association put together an ethics manual, which is available to all physicians to get ethics training. But the point José made and the point this question makes is that there isn't a standard inclusion of tobacco harm reduction and nicotine in the training of doctors, dentists, midwives, pharmacists. And that is of grave concern. If you take that there are almost 1.4 billion smokers on earth, they're all seen by health professionals. And if those health professionals haven't been taught properly as part of the official curriculum that they are taught, then this is obviously a major flaw. To answer the question, Joseph, yes, the Africa Harm Reduction Alliance, along with its partners, which includes CASA, Vaping Saved My Life, and then our regional network partners in Asia, the Asia Harm Reduction Alliance, and then also the Pan-American Harm Reduction Alliance, and also all the groups in Europe. We plan to put together a small curriculum on tobacco harm reduction, and specifically nicotine, that would be made available to all health professionals at their level to better understand what nicotine is and what it is not. I think here we had a consumer advocate explaining to some doctors that nicotine is not the real issue in smoking, but people, as often is said, people die from the tar, not from the nicotine. And nicotine is a drug which has been used for 40 years in the pharmaceutical industry. And if we want to know better, if we want to have more evidence-based training for health professionals, we need to start that ball rolling. So yes, within the Harm Reduction Alliance networks, that's exactly what we will do. José?
But I think the more important thing is that it should be general harm reduction, not just focus just on tobacco, because we also need to know about harm reduction in relation to food, harm reduction in relation to other drugs, and just general harm reduction. And more importantly, what we need to be doing is to be educating the public. So it should not just be about putting it in the curriculum. We do harm reduction work in food, and it's amazing how people know more about how to feed their cars than how to feed themselves. No one is going to put diesel in a petrol car. No one is going to put 93 octane in a high performance car. But what we put in our mouth, we have absolutely no idea what we're doing to ourselves. We have absolutely no idea how it gets absorbed. So basic education of the population on the things that matter, things that you put into your mouth, things that you put into your lungs, so that you have basic working knowledge of what you're doing to your own architecture.
Thank you for that, Khosi. We've reached the end of our panel. Do you have a question, ma'am? Okay, fine. Yes. Please repeat on the mic. Yes, you're world famous.
So just say what they say is very correct. So I just came here for just curiosity. So, but I found that this was very informative for me. I have learned a lot of things that I'll be applying into my life, because I also into helping people to know how to eat, how to take care of themselves, and how to feed themselves mentally and physically and spiritually, holistic approach, because it doesn't help you feed the other, you don't feed the other. They need to balance. If you don't have balance in life, you're not going to go anywhere. Career, otherwise, you need to balance everything. Everything needs a balance. And start with you understanding how you eat, what is your eating pattern, what is your, the nicotine things, how you smoke. Is it harmful? Some people, they don't know that it's harmful. They just know that when they smoke, they feel better and all those things. We are not educated on a lot of things. Even with money, we don't know how to invest and stuff like that. We need holistic education. That's what I was saying.
Thank you very much.
Thank you.
So last word from each of our panelists. Anders, any last comments from you? And then we'll...
No, again, I mean, the only thing I really want to stress is be truthful, simple as that.
Thank you. Joseph? Fine. Thank you, Joseph. Kurt, and then we'll end with our president.
I think, yeah, it's just that we need to start bringing empathy, honesty, and because there is a lot of trust that's been lost, and that's one thing we don't need is trust. And I'm hoping that particularly the medical fraternity and places like the UK and New Zealand step up to COP10 and insist that there needs to be a very clear relook at this, and parties like the activist community need to be present at those discussions. It's vitally important that we all share and be truthful about it.
Thank you, Kurt.
Just a few things, having observed that if you lie long enough, it becomes a synthetic truth, a manufactured truth. And that, to the question that you asked initially, what could be done in South Africa? I just imagine with over 10 million smokers.
11 million, 11.7.
11.7. If they came together, they'd be a group larger than all the members of political parties put together in South Africa. What a power base. But lastly, that we should take seriously the concerns that are being raised about youth uptake and work together to deal with the issue of youth uptake. If you look at what's happening in the UK, vaping is mainstream, but there's now a problem where they are concerned about the youth uptake. So it's something that we should not put aside, but our major stride should be at saving lives. And back to what Kate was saying, we should bring back the spotlight on the people that suffer at the end of life because of the habit of how they were taking their nicotine, and that's where the most difference should be made, and that's what we should have. So we should not leave them to die because we are worried about youth health. We should do both together, but the greater emphasis should be to reduce lives that are lost unnecessarily, preventable deaths.
Sorry, Dylan. I think in terms of the youth update, we're probably looking at the symptom and there might be something underlying. And if we focusing purely on the symptom, we might skip what the real underlying issue is.
No, I'm actually not saying you should look at it as a symptom. That's exactly the point.
Yeah.
But unless you create a dialogue around it, you are not going to be able to know what drives it. If we're stressing our kids at school and the quickest way to relieve stress is being stimulated by nicotine so that you can forget that you live in a hostile world, what are we going to do about it? That's what you're talking about. And all I'm just saying is that let's open dialogue and let's discuss it. Let's find out what are the driving factors and what are the appropriate solutions.
Absolutely.
And as Jose said, it's all about lives, and especially the quality life-adjusted years that we can save for those adult smokers who cannot or will not quit. That harm reduction is their way out. It's their fire escape. So on this note, I'd like to just warmly thank all of you online, on site, for attending this Africa Harm Reduction Alliance Summit. Thank very much our speakers, world-class speakers from all over the world, who've now given us wise insights into what can be done at global level, at regional level, and here in South Africa. Thank you very much for joining our summit, and we wish you all well, and we wish all of our tobacco harm reduction advocates well, leading up to COP10 in November this year. Thank you very much.
Thank you very much.